Okay, let's unpack this. This deep dive is your direct shortcut right into the mechanical engine of human movement. We're doing an in-depth exploration of the pelvic girdle, hip, gluteal region, and the thigh. We're tackling some pretty complex anatomical sources, the diagrams, the layers, all the spatial relationships. And our mission here is to convert all of that into a clear functional map that you can actually hold in your mind.
And that mental map is so critical.
Yeah.
Because what's fascinating here is that this region, it's not just a collection of parts. It's more like a complex biological machine designed for one amazing feat.
Which is?
Withstanding massive compressive forces.
Yeah.
I mean, it transmits the entire weight of your upper body, all while allowing for a really efficient bipedal gait. So we're going to build this area up, layer by layer, starting right from the outer sleeve of the thigh.
Okay, let's do it. That outer sleeve. The thigh is really organized around that central femoral shaft, and it's all encased by this dense, deep connective tissue called the fascia lata. And this deep fascia, it isn't just a simple stocking, it's a structural element. It sends these internal divisions, these septa, that attach posteriorly to the linea acetabulum on the femur.
And that's what divides the muscles.
Exactly. It divides them into three very distinct osteofascial compartments. You've got your anterior, your posterior, and your medial.
And we really have to emphasize the strength of that fascia lata, particularly on the lateral side. It thickens up dramatically to form the incredibly robust iliotibial tract, the ITB.
The ITB, yeah. Everyone's heard of that.
Right. And this dense band, it acts like a powerful stabilizing strut for both the knee and the hip. Its upper end anchors the tensor fasciae latae muscle and a huge part of the gluteus maximus. And then it runs all the way down to attach on the tibia at a spot called Gerdy's tubercle. That lateral reinforcement is just key to our posture.
That's a great visual. A massive fibrous anchor system running down the side of the leg. Now, thinking about those internal partitions, the sources mention that the intermuscular septa aren't equally strong.
That's right. The lateral septum, which separates the anterior muscles from the short head of the biceps femoris in the back, is notably thicker and stronger than the medial one.
And that makes sense biomechanically.
It does. It just reflects the different stresses placed on the lateral versus the medial aspects of the thigh when we move. Now, if we step back to that superficial layer for a second, we have to talk about how things get in and out of this fascial sheath. There's a very important entryway called the saphenous opening.
You can picture this opening as a sort of window in that deep fascia, right?
Right.
It's just inferolateral to the medial end of the inguinal ligament.
Yep.
And it's typically covered by a sieve-like membrane, the cribriform fascia, so named because it's pierced by vessels. But what's its main function?
Its crucial function is to allow the long saphenous vein, which is the major superficial vein of the leg, to pass through that deep fascia and join the much larger femoral vein in the deeper circulation. It's a critical landmark.
Okay, so following those vessels deeper, just under the inguinal ligament, we find this remarkable structure, the femoral sheath.
Yeah, this is a really neat piece of anatomy. It's a funnel-shaped extension of deep fascia that organizes the whole neurovascular bundle as it enters the thigh.
And it contains three distinct vertical compartments.
3, yeah. Moving from lateral to medial, the largest lateral one holds the powerful femoral artery. The intermediate one carries the femoral vein.
And then the third one, the medial one, is the tiny but clinically very significant femoral canal.
Exactly. And what's interesting is what's not in it.
Right, it doesn't have a major vessel.
Yeah.
It's mostly lymphatics and a bit of fat. So why is that little bit of empty space so important?
Well, it's a physiological release valve. That canal provides the space for the femoral vein right next to it to expand when venous return increases, like during heavy exercise. But it's also the weak spot. It's the potential path for a femoral hernia.
Ah, okay. So we've mapped the tunnels. Now we need to look at the architecture itself, the bony framework, starting with the hip bone, which is actually a fusion of the ilium, ischium, and pubis.
Right. And the hip bone forms the pelvic girdle. And because its main job is absorbing and transmitting just massive amounts of weight, the compact bone inside it is heavily reinforced along very specific lines of stress.
Where specifically?
The sources really detail this reinforcement, particularly in the upper part of the hip socket, the acetabulum, and along the arcuate line. This is basically the path that body weight takes from the spine across the sacrum and toward the head of the femur.
And the focal point of all that is the acetabulum, the hip socket. It's this deep hemispherical cavity, and it faces sort of antero-inferiorly.
And the actual joint surface, the part with the cartilage, is the C-shaped lunate surface. And what's critical is that it's widest at the top, the dome. because that is precisely where body weight is transmitted to the femoral head when you're standing or walking.
And to make it even more stable, the socket is ringed by the acetabular labrum.
Yes, a fibrocartilaginous rim. This is so important. It deepens the socket quite a bit, and it constricts the opening. Functionally, this makes the joint more stable and helps maintain a fluid seal for joint nutrition.
Now, moving down from the acetabulum, we find that huge hole, the obturator foramen. It's almost completely closed off by the tough obturator membrane.
Almost, but not quite. It leaves that little gap, the obturator canal, which is the exit route for the obturator nerve and vessels, to get into the medial part of the thigh.
We should also highlight the ischial tuberosity.
Absolutely, the sitting bone. It's the bony landmark we sit on, but its real significance is structural. It's the attachment point for the hamstrings, the powerful posterior thigh muscles.
And that's where you see avulsion fractures in young athletes.
Exactly. The tendon pulls so hard during an explosive movement, it can actually pull a piece of the bone away.
Okay, let's bring in the femur now, the longest and strongest bone in the body. Its proximal end has the head, the neck, and then those two big bumps, the greater and lesser trochanters.
And the geometry here is everything. The femoral neck sits at an average angle of about 127 degrees relative to the shaft. That's the angle of inclination. And tiny deviations in that angle can critically affect your gait.
And those bumps, the trochanters, are all about leverage. The lesser trochanter is the key attachment site for the powerful hip flexor, the iliopsoas.
Right. And here's the immediate clinical correlation that you have to visualize. The blood supply. The blood to the femoral head runs through these ascending retinacular arteries that cling right to the femoral neck.
They're very exposed.
Incredibly exposed. So if you have a displaced fracture of the femoral neck, especially an intracapsular one, those vessels are at extreme risk. And if you cut off that supply, you risk a vascular necrosis, where the bone tissue actually dies.
That potential for vascular catastrophe brings us perfectly into hip joint mechanics. We know the hip is a ball and socket joint, and it's famous for its stability. Why is it so much more stable than, say, the shoulder?
It's a combination of things. The deep socket, the labrum we talked about, and crucially, the capsular ligaments. These ligaments wind up and get really tight in extension, which basically locks the hip in place when you're standing upright.
Let's talk about those heavy hitters. The iliofemoral ligament is the strongest ligament in the whole body. It's shaped like an inverted Y, and it sits right at the front.
And it acts as the primary check against hyperextension. What that means practically is that it's an energy saver.
How so?
Because it tightens fully. When you stand up straight, you can stand with a minimal muscle effort. You're just sort of hanging on that passive ligament tension instead of constantly firing your postural muscles. It saves a massive amount of energy.
So given all that incredible stability, what happens when the joint geometry itself is just a little bit off?
Yeah. Now we're talking about femoroacetabular impingement syndrome, or ACI. This is when there's abnormal contact between the top of the femur and the rim of the socket.
And this happens because the bones aren't shaped perfectly.
Basically, yes. You can have a cam deformity, where the femoral neck is too bulky, or a pincer deformity, where the socket rim is overgrown. In either case, during deep movements like squatting, the bone repeatedly traumatizes the soft labrum.
And that leads to tears.
Tears, cartilage damage, chronic pain, and eventually a much higher risk of premature osteoarthritis.
So let's tie this all back to function. Let's talk forces. When you're standing quietly, each hip only supports about 1/3 of your body weight. But the sources point out this astonishing fact.
I know where you're going with this.
During the single limb stance phase of walking, when you're balancing on one leg, the joint reaction force can skyrocket up to 4 times body weight.
It's an incredible number. And that exponential force increase is the key to understanding bipedal gait. That force isn't just from your weight, it's from the counterforce that your hip abductor muscles have to generate.
The gluteus medius and minimus?
Primarily those two, yes. They have to produce a pulling force that's about twice your superincumbent body weight just to keep your pelvis from dropping on the other side.
And if they're weak?
If they're weak, say from a nerve injury, they can't do it. The pelvis drops uncontrollably on the unsupported side. That's the classic uncompensated Trendelenburg sign.
That really underscores their importance. Okay, finally, let's quickly match the muscle actions and their wiring. We generally have that one compartment, one nerve rule in the thigh, which is a great starting point.
It's a very helpful rule of thumb.
So the anterior compartment, the extensors like the quadriceps, they're mainly the femoral nerve. The medial compartment, the adductors, mostly the obturator nerve. And the posterior compartment, the hamstrings, get the sciatic nerve.
And a really vital deep flexor dimension is the psoas major. It's technically a trunk muscle, but it has a massive influence on the hip. And the critical point for mapping it is that the entire lumbar plexus, the nerve network for the anterior thigh, is literally embedded within the substance of this muscle.
Wow, so the psoas is an essential landmark for any surgery or imaging in that area.
Absolutely. Now, in the gluteal region, deep to the huge gluteus maximus, you find the small, short external rotators.
And the key landmark among them is the piriformis.
Piriformis is the key, because the sciatic nerve, the thickest, longest nerve in the body, usually exits the pelvis just below it. This relationship is so important because if the piriformis gets tight or hypertrophied, it can compress the sciatic nerve, leading to a condition called piriformis syndrome.
Understanding that neural highway is critical. Let's finish with the arterial supply, which starts with the femoral artery.
Right, but the real workhorse for the muscles is its large primary branch, the profunda femoris artery, or the deep artery of the thigh. It gives off a series of perforating arteries that supply pretty much the entire muscular cylinder.
And we have to come back to that idea of a circulatory backup plan. What happens if the main femoral artery is blocked?
The body relies on anastomosis, these natural connections between smaller arteries. Specifically, the trochanteric and cruciate anastomoses link branches from the gluteal and circumflex femoral arteries around the hip. It's a safety net, a collateral pathway that ensures blood can still get to the limb even if the main highway is blocked.
So, to recap, we've mapped the tight organization of the thigh's fascia, located the robust bony architecture of the hip, and detailed the muscle compartments, really emphasizing that crucial role of the abductors and the critical vascular supply to the femoral head.
We hope this deep dive provides you with that clear, structured knowledge you were looking for, making this really dense material easier to recall and visualize. Truly understanding the mechanics of the pelvis and hip is key to appreciating just how efficient our movement is.
And as we close, we want to leave you with one final thought to explore on your own.
If we connect all this to the bigger picture, consider this. Given that the joint reaction forces on the hip routinely hit 4 times body weight during simple walking, and we now live so much longer than our ancestors, how might that increased total number of loading cycles, and the wear we call osteoarthritis, continue to drive subtle mechanical shifts in the requirements for hip joint replacement technology in the future?